So some of the things we're going to talk about in this advanced cardiac life support is the nurse's role. That's what we've been talking about all morning. Um, the rhythms, knowing what the rhythms are, and some of the meds that we're going to be giving, and what does the RN do. So y'all will all have opportunities to go and take an advanced cardiac life support course probably not long after you get your license, which is wonderful, and you should go on and do that because it's going to help you to be a better nurse and better prepared for code situations and preventing code situations, because that's the deal. We want to do that. I worked with a gal many years ago, and she did not like working with us in CCU because we didn't have enough codes. And we all thought she was foolish because we felt like we had prevented a lot of codes by our interventions and all. But she was young and full of adrenaline, and she went to work with the ambulance service, which is a great place for them because they do encounter the codes, So, and then I think she kind of burned out, and I saw later that she was working at a women's shelter. So, you go full circle sometimes, but you will encounter codes in any area that you work, so I suggest that you go on and do the advanced cardiac life support as soon as you can, because it's going to help you. And it's not as intimidating as it once was. They've made it more user-friendly and what have you, so it's a good thing. So it'll teach you all about defibrillation, and there are biphasic, monophasic, and all that. We don't care that you know that right now. You're going to use what equipment you have, and the idea is if there's VFib or VTAC and they're pulseless, we're going to defibrillate as quickly as possible. And until the defibrillator gets there, we're going to do CPP. We already know what CPR is, but now we're only doing, in the hospital we're not, but out on the streets or what have you, we're doing just the compressions, aren't we? Because that's what it says we can do, because the circulation is what we need to be doing versus the breathing. But when we're in the hospital, we have other means with us, so we'll use the bag valve mask and what have you. So we will be doing the full CPR. I know everything will say stop the oxygen to avoid the hazard of fire. I will tell you, I have done codes for many years. I've never seen an explosion during doing the code. I have never gone and turned oxygen off somewhere out in the hall. We just quit bagging, don't touch the patient. I've never seen the oxygen turned off, so I hope that's never a question, because that's a fallacy. We do want to make sure that no one is touching the bed or the patient. So we will scream, clear, and that means everybody shuts up and everybody makes sure everybody else is, if someone next to you is leaned in and really in tune to talking to somebody, you push them aside and say, are you touching the bed? Because you don't want them to get a little jolt as well. So that's what we mean by clear. Everybody clears the bed. And then we immediately watch the monitor, see what's happening. Of course, before we can even defibrillate, we have to put the patches on. So I got ahead of myself a little bit. But we want to put the conductive patches on, and I don't think anybody uses the gel that you rub together and put on them anymore. Everybody uses the pads. If they're real hairy, you might have to put a pair of pads on and snatch the hair off to get it out of the way, and then put a new pair of pads down. But the pads show you how to put them on. It's simple. One pad at the third intercostal space, and the other one, the fifth intercostal space on the mid-axillary, left mid-axillary line, so that we get a good transference of the electrical shock. We'll say use firm pressure. Now we even have some that you don't even have to be touching the patient. So, that's just depends on where you are and what kind of equipment you have. So, but the big thing is we don't want to be touching the patient. So tell them to, move over, pull back, whatever, so clear. Here's the placement. Third intercostal space, and down here the fifth on this side. Okay? Now, they also have the AEDs, and you'll notice here in our building we have one down across from the elevator. They're usually located on the first floor across from an elevator in a prominent place where people would be going. These are for lay people to use, so certainly we are able to use those. So we just follow the instructions on them. We want to put the patient on a firm, dry surface, stop CPR, make sure nobody's touching, put the pads on them, and like I said, if they're real hairy, you might use a pair of pads to get the hair off and then put a new pair on. Put them in the correct position and then turn it on, have an analyze button, and it might take a little while, so just wait, and then it'll tell you whether a shock's advised or not. Okay, so we'll only recommend shocking, defibrillating for VFib only, okay, ventricular fibrillation only. And if it says shock, then you do the shock, and you repeat, and then subsequent if you need to. If you're unsuccessful, then you start back with CPR. And these are the same things that go true for a defibrillator in the hospital. We'll do CPR until the cauterized, then we'll put the pads on, we'll see what we're getting, and then we will, of course, the AED will tell you whether you need a shock. In the hospital, it won't say, hey, you need a shock. You've got to know your rhythms. You've got to know if it's VFib. But those are what we will do. Some of the other jobs the RN may do is that she may be responsible for clearing out the room of unnecessary people. Very often in the hospital setting, you'll have people come from different areas, a code team or something. Often someone from the ER, a doctor and a nurse or two will come to manage the code, but until they get there, you got to do what you got to do. So the nurse will be the person that demands that they get the cart there, the code cart, and anybody can bring the code cart. Just unplug it from the wall and bring it on in there and get them hooked up. CPR will be going on, whoever's there. You remember, when you're going to start doing CPR, you better run to the door and scream, I need help, call a code or something, or you're just going to be in there doing it by yourself. So you have to get summons for help. Then you can do CPR, or you can allow other people that come in, other techs or what have you, to do some of that work. And remember, you got to swap them out, because that gets pretty tiring pretty quick. You do a few cycles, then you check the pulses, and we check pulses femoral and arterial. Is usually what we do. And if they don't have big IVs in, we try to get a couple of big IVs in, because we're going to be pushing some fluids and all on them. But we can do CPR while some of this stuff is going on, and then when the cart gets there, we can defibrillate if necessary. And the nurse's role is going to be to have somebody be the recorder, to take down all the times, when events are happening, when meds are given, when shocks were delivered. Have someone out at the desk call the family or what have you. And there's different things about, do we have families in the room while we're defibrillating and coding and what have you. And there's different thoughts on that. It depends on a whole lot of things. But usually we try to get them out of the way, because there's usually not a lot of room. And it's also pretty hard to see that. But sometimes it's good that they know that you're doing everything you can as well. So there's kind of a little bit of a dilemma there for some people. That's about all I have to say about that. But you need to go on and do your ACLS as quick as possible. It is evidence-based. So they research and do and know what are the best techniques. They are just guidelines. So if you see different places go a little bit differently, that's just to say that this is just a general guideline. It's not you've got to do it this way. So, but this will make you a better nurse, It will give you so much insight and so much confidence. So you just need to back your ears and get on and get in a course wherever you go. Just about every place has courses, or you can find them online and what have you. So do this. It'll be a good thing for you. Okay, thanks. That's all I got for you today. Oh, I will put some med things up here, just about so you can look at them. You may already have these, but if you don't, so this is on antihypertensives, Monopril, antiarrhythmics. If these help you to memorize, or not memorize, but learn some of these, that's a good thing. A little bit about nitroglycerin. We can have it quick or we can have it slow. Ointment or sublingual or translingual spray. Some information on digitalis. We don't use digitalis or Lanoxin a whole lot anymore, but we do see patients with it. And one of the things, one of the side effects is that you can have yellow vision. So it's one of those things. And you can get digtoxic. Here you can see, keep the levels between 0.5 and 2. He's getting a heart checkup here. It's kind of cute. Calderone or amiodarone, the enforcer. That's really a big drug we're using a lot of now. So as you can see, these are good cartoons. I think they kind of drive it home. Current life-threatening VFib, VTAC, decreasing the cardiac conduction and automaticity. Side effects. Okay. Some of the other meds. ACE inhibitors. Remember, that's angiotensin converting enzyme inhibitors. Again, the ACE inhibitors, if these help you. World Series of Hearts, I like that. ACE inhibitors, get it? And here we go again. Increase the cardiac output. Or they don't increase cardiac output. They don't increase the heart rate. And they don't increase cardiac contractility. That's why they do that. They're good. Because their action is they decrease peripheral vascular resistance. But they don't cause these side effects. Okay? Morphine, Yahoo, very good at controlling pain. Look at the side effects though. Side effects of alpha and beta blockers. Alpha blockers, beta blockers. Somebody once told me the alpha, we have one heart. Now these both work somewhat on heart and lungs, but generally alpha on the heart, beta, you got 2 lungs, B, 2 lungs, get it? Okay, and you see what some of the things are. But anyway, if that helps you, okay. If it doesn't, but like I said, they both do work on heart and lungs. So anyway. Use it. This is really important on these beta blockers. Using them early in MIs, especially the first year after an MI, has really decreased infarcts in patients and increased survival. So that's a really wonderful thing that some of these drugs have done. I think I just had that on there. I've got it on there twice. Must have been important. It's the beta 1 that affects the heart and the beta 2 the lungs. I'm sorry, I got ahead of myself. Okay. Channel blockers, you'll see, take care of a lot of patients with channel blockers, preventing spasms. Okay. VND, very nice drugs. Oh, whatever helps you to work on it. And they look at why they work. decrease the contractility, decrease conductivity, decreasing oxygen demand. And that's what it's all about, isn't it? That's supply and demand.